Good morning. I would like to thank the organizers and the BOS for inviting me for the talk. Our journey into hip arthroplasty started with Sir John Chanley doing his cemented hip replacement in 1960s. It still continues to be a very common and very popular arthroplasty. Today, long-term results are available. Conventionally, we have been doing cemented hip arthroplasty in the DOR C type of osteoporotic bones. And the registry data shows that at 5 or at 10 years, the survivorship or the revision rates of uncemented hips are definitely higher as compared to cemented hips, mainly because of these periprosthetic fractures that occur in porotic bones and which need revision. So cemented hips have a lower implant-related complications and revision rates. They also have improved post-operative outcomes such as residual thigh pain and mobility. So if you go through literature, cemented stems definitely have done better than uncemented stems. But over the years now, the amount of cemented hips are on the decline. The reasons being these kind of catastrophic failures that we have seen. But if you analyze them, we realize that the main reason for the failures was polywear, and selecting a better bearing would definitely reduce this fear. Another reason why surgeons nowadays avoid doing cemented hip is the fear of intra-op complications, the bone cement implantation syndrome, and lack of confidence in their own cementing techniques. Another reason is because uncemented is perceived to be easier than a cemented hip. Also, old cemented hip is looked at as an old school kind of a procedure, and definitely industry is also pushing towards it because of profit margins in uncemented hips. But can you avoid a cemented hip in these kind of osteoporotic femurs where there is hardly any bone stock because of old infection or old trauma? Can you avoid a cemented hip in a short patient with a dysplastic hip? Also, cemented hip is definitely 30 to 40% cheaper for the same bearing if you choose it. Cemented hips definitely are easier to revise than an uncemented hip. So younger and budding surgeons need to learn and perfect their cementing techniques and should not just give up on the cementing as it's happening nowadays. So if you select a good cemented stem and cement it well, you can definitely have better results. So cemented hip, basically stems come into two types, the composite beam or the taper slip type. The older of the Chanley was a typical composite beam type where they are usually collared, they have a rough finish, they have flanges or grooves, and the main thing is you have to have a strong bond between the bone, cement and the stem. In this kind of a construct, basically the forces are transmitted from the femur onto the stem to the tip of the implant and onto the distal femur. So the proximal femur is generally bypassed and you can have some kind of resorption there. Also, the perfect bonding needs to be established between the bone, the cement as well as the implant, and hence the cementing technique needs to be good, and this is not so forgiving. The taper slip type is the more common type. Most of the popular stems are of this type where the typical stem is collarless, is polished and taper, double or taper depending on the manufacturers. Here the implant is supposed to subside a few millimeters so that the radial compressive forces are then transferred or converted into the hoof stresses, which then load the proximal femur, and there is no stress shielding or osteopenia. Here the cementing technique need not be perfect, and definitely this is a bit more forgiving kind of an implant, and hence this is the popular stem that most of us are using. Again, the implant is made up of stainless steel or cobalt. You can have an implant in multiple options of lengths, offsets as well as thicknesses. You can combine it with anything on the acetabular side and you can have the bearing of your choice. So your bearing is not dictated by it. Again, a cemented stems, you have multiple offsets and lengths for the same canal size. Hence, you can reconstruct the proximal femoral geometry more accurately in a cemented hip. Hence, the limb length discrepancy problem is definitely lesser with cemented hips. You can basically do to whatever surgical approach that you are happy with. The newer retractors definitely allow us to do it through a smaller approach. A neck cut is not important if it's a collared implant, but you can always use a neck cut guide. Entry is very important, needs to be posterolateral so that you end up with into the center of the femoral canal. I feel this is the most important step in a cemented hip. Once you have opened the canal, you need to really wash out all the debris, the fat, the bony particles through into your canal, and you should have a dry canal at the end of it. Typically, I give a wash of up to 1 to 2 liters. Pulse lavage definitely would help here. They take some time here, be happy that with whatever you've done, and you should end up having a nice dry and a clean canal at the end of it, because this has a big implication in the complication that we can have. Once that is done, you can serially broach the femur till you reach the desired size. If after broaching, if you feel your offsets are not reconstructed accurately as what you have planned, then you can definitely change the offsets very easily because the implant comes in multiple offsets. Use a cement restrictor. Typically, we used to use this hard-hinge restrictor previously. Now these newer cement restrictors of methyl methacrylate are available. Typically, we place them 1 centimeter distal to the tip of the implant. After that, again, I would give a thorough lavage to the canal and have a dry canal. If there is bleeding, you can pack it with hydrogen peroxide, but always never forget to vent the canal because hydrogen peroxide also can lead to some amount of embolism. Best would be to vacuum mix the cement so as to have a good uniform cement mantle and lesser chances of complications. Then cement pressurization is done using a cement gun and a proximal seal. Give extra importance to the zone 1 and 7. Typically, the cementing is inferior in these sites, so you can definitely do some digital cementing in these parts. Take your implant and introduce it slowly. The surgeon's thumb can act as a seal on the medials and also prevent the implant from going into varus. Insert the stem till the desired mark. Keep it there or keep sustained pressure so as not to prevent the migration of the implant during polymerization. Again, do a trial reductions, check your stability and limb length correction, and you can end up with this kind of a nice cemented hip which looks good and will definitely last longer. A minute about the most feared complication, the bone cement implantation syndrome. It is characterized by hypoxia, hypotension, loss of consciousness, can end up with arrhythmia then arrest sometimes. It can happen in any cemented procedure, a hip or a knee or anything. Severe reaction is seen in about 3 to 5% of cases. Mortality can range between 0.1 to 1% according to literature. But in severe cases, definitely there's a higher 30 and 1 year mortality rate as shown by multiple studies. Initially, it was thought that monomer is the main culprit here, but now we know the embolization is the main problem, and the emboli going and lodging into the lungs, the brain, or the heart can cause further problems. Histamine and complement also plays its role. It's now believed that all these about 4 processes actually have an impact or lead to the problem, and the outcome will depend on what is the patient's physiological response and his reserves. Donaldson has classified this into 3 grades. Grade 1 is where the PO2 falls up to 94 and the BP falls up to 20% from the baseline. Grade 2 is where the PO2 falls to 88 and the BP can fall up to 40, and grade 3 is a frank severe collapse where it needs a CPR. Basically, to manage or to avoid this complication, we need to anticipate, detect it early and aggressively manage it. Typically, it's seen in patients with ASA grade 3 or grade 4. Older male patients have a higher chance. Patients who have previously have pulmonary problems or renal problems have a higher chance. Osteoporosis, metastasis, and pathological fractures have a higher chance. Patients on diuretics and warfarin definitely have a higher chance. Once you have a high-risk patient, discuss with your team, make your own protocol. A low-dose spinal without sedation is the best anesthesia. Try and avoid GA. The anesthetist is to be told before we start mixing the cement so that they can maintain the BP up to 20% of the pre-existing or the pre-induction values. They need to oxygenate, use the drugs depending on patient to patient. ETCO2 need is the first, falling ETCO2 is the first parameter that you can see. Delirium and dyspnea is also clinically should be noticed and action should be taken. And then anesthetists need to treat it like a right ventricular failure. Basically, on the surgeon side, we need to know when we open the canal, when we cement, or when we insert the process, there's a chance of this. So on the surgeon side, we need to achieve meticulous hemostasis, suck out the entire canal and give it 2 minutes, nicely wash out the canal and remove all the debris, the fat, etc. Prepare your femur well, plug and dry the canal well, vent the femur without fail. Inform your team before you start mixing it. Low viscosity cement and vacuum mix definitely helps. Pressurize the cement using a retrograde cementing with the gun and use a vent.
Atul, you'll wind up, please.
Okay, and use a shortest time. So why do I still cement my implant? Because excellent results are there. And with improved techniques, definitely results are better. It's very easy to learn and teach. It's cost effective and definitely can cope up with anatomical variations, and it's very easy to revise. So I'll still prefer a cemented hip over my uncemented.
Thank you, Atul.